In this lesson, we'll take a look at restrictive lung disorders, specifically a group of disorders known as pneumoconiosis, which limits the expansion of the lung. And then we'll finish up the lesson by taking a look at some vascular disorders, pulmonary edema and pulmonary embolism. So let's take a look at the first type of restrictive lung disorder. It's actually a group. We call these pneumoconioses, right? So this is a group of disorders where the patient has impaired lung expansion, right? They're not able to expand their lung and a loss of their total lung capacity. So we can divide this simply into two groups. The first group has abnormalities of the chest wall, which is going to limit or impairs the lung expansion. Right? Think about people having a kyphosis or scoliosis. Kyphosis is kind of that hunchback where we have an increased thoracic curve. Scoliosis is the side-to-side curvature of the spine. Polio, ALS, botulism, and even muscular dystrophy, right, can all cause abnormality to the chest wall, again, limiting lung expansion. The second group of pneumoconiosis we can think of as diseases, a group of diseases that affect the supporting framework of the lung, right, the actual tissue of the lung. Two good examples of this. One would be idiopathic pulmonary fibrosis, right? Fibrosis is the formation of scar tissue, idiopathic, right, for no known reason. And then a variety of occupational diseases can also affect the framework of the lung. So we'll take a look at the pathophysiology, but we'll look at it from the perspective of not the chest wall abnormalities, right? That's covered in the musculoskeletal system disorders. We'll take a look at it in the context of from occupational. Okay, so when it's from occupational, it's a chronic restrictive disease resulting from a long-term exposure to different irritants. Those irritants result in inflammation and eventually fibrous tissue developing within the lung. And there's a gradual destruction of the connective tissue within the lung also. As this fibrosis gets worse within the lung, the functional areas of the lung are going to be lost, right? And this is when the individual is going to have difficulty breathing. So the onset is basically insidious. It takes, over a long period of time. It just doesn't develop tomorrow. It comes on over a long period of time, where the individual has dyspnea at first, and then the breathing is just going to get worse and worse as time goes on. Not much you can do once that fibrosis kicks in. There's not much we can do. So really trying to end the exposure to whatever the irritant is, and then preventing or treating any secondary infections that may come about. So here's just an example of some occupations, right? Coal workers, where they breathe in coal dust. Silicosis, where they breathe in silica, right, from cutting stone or sandblasting. Asbestosis, historically was in insulation and shipbuilding. Farmer's lung, where they're breathing in fungal spores, that type of thing from hay. Right, so these are all examples of pneumoconiosis from occupational. Okay, so let's switch over to vascular disorders. We'll take a look at the first one, which is pulmonary edema. And very simply, this is going to be fluid collecting within the alveoli and then the interstitial area, right, the area between the cells in the lung. And ultimately, if you start to fill the lung up with fluid, it's going to reduce the amount of oxygen and that's going to get into the blood. And this could also interfere with lung expansion, right? Think about your fluid, your lungs being filled with fluid. They're not going to have the same expandability. So some of the things that cause this, we've actually talked about in the cardiovascular system. One would be left-sided heart failure, right, where the heart on the left side is not pumping the blood out to the systemic circuit. So now the fluid or the blood will back up into the lungs and the alveoli fill with fluid. It could also be caused by inflammation in the lung, and that inflammation increases the permeability of the capillaries, right, and that's going to cause more fluid to be in the lungs. Hypoproteinemia, right, low protein levels decrease osmotic pressure. Right, whenever we have low, especially albumin, that's going to allow the fluids to move out of the bloodstream into the tissues. And one of the tissues that it can move into is going to be the lung. Now, this can result from either kidney or liver disease, the liver especially, because that produces albumin. Another reason for pulmonary edema could be just an obstruction of the lymphatic vessels, maybe from a bronchiogenic carcinoma, right, from lung cancer. So, what are some of the clinical manifestations of pulmonary edema? When it's mild, the patient will have a cough, orthopnea, meaning they'll have difficulty breathing when you lay them down. They feel better, being upright, sleeping upright or sitting upright, that's for sure. And then you can hear the fluid in the lungs. It sounds as rails. Again, my example always is if you just take your hair and rub it in front of your ear, right? That kind of sound there, you'll hear that crackling sound as the air moves through the fluid. As the congestion gets worse, right, as the lung fills up with more and more fluid, there'll be hemoptysis, right, coughing up of blood. The blood, the sputum will be frothy and blood tinged. The breathing becomes more and more labored. Again, think about all this water inside the lungs. The patient feels like they're drowning, and again, it just makes breathing that more difficult. So the best thing to do is, as far as pulmonary edema, is to get the liquid out of the lungs quickly. So there's medications that will do that. But then to treat the causative factors, right? What's causing it? Is it that left-sided heart failure? Is it the low levels of albumin? That type of thing. And then finally, just to do some type of supportive care. It is possible that these patients would be put on a ventilator until the problem is solved. So here's a picture that's showing the blood moving into the area of the capillaries, where again maybe there was just high pressure here, hydrostatic pressure, and it pushes the water out of the bloodstream into the interstitial area here, and then the fluid moves into the alveoli, right, into that area there. So when we have more fluid in here, there's going to be less and less gas exchange. The other thing that happens is the fluid can actually dilute the surfactant. If you remember, that's the chemical that keeps the alveoli from collapsing or sticking together, so that we can expand them and expand the alveoli when we breathe in. So by reducing the surfactant, now the alveoli will collapse. So ultimately, we didn't get the oxygen moving through the water into the bloodstream. So this blood that normally would be, rich in oxygen going back to the heart, right, is not going to be as rich in oxygen. Okay, the last disorder that's a vascular disorder is pulmonary embolism, or here I have pulmonary embolus. Very simply, guys, this is a blood clot or a mass that obstructs the pulmonary artery or any one of its branches. The effect of the embolus depends on the material, the size, and the location. I'll show you a diagram in a moment, some of the different possibilities in the lung. Now, small pulmonary emboli may be silent unless there's a bunch of them affecting a large area of the lung. Sometimes people don't know they have them. While on the other hand, a large embolus, right, may cause sudden death. That may be the first sign that there was a problem, right, that the patient dies. 90% of the pulmonary emboli originate from, look at this, deep vein thromboses in the legs. And again, these are preventable, right, by just kind of moving around, preventing stagnation in those deep veins of the leg. So we'll take a look at some of the clinical manifestations. A small emboli or small embolus is going to cause some transient chest pain, kind of comes and goes, a cough, and a little bit of dyspnea, shortness of breath. Where a larger emboli or embolism is going to be of sudden onset and is going to be increased chest pain, coughing, and even deep breathing. Tachypnea, which is rapid breathing. Dyspnea, right, labored breathing, difficulty breathing. And then later, even hemoptysis and fever. Again, hemoptysis being a coughing up of blood. There'll also be hypoxia. Again, we're talking about, just to go back a minute, with larger emboli. There'll be hypoxia, low oxygen levels. That stimulates a sympathetic response, which causes anxiety, restlessness, pallor, right, paleness, tachycardia. And then if there's a massive embolism, right? A massive emboli, the patient will have severe crushing chest pain, a drop in the blood pressure, a weak rapid pulse, and then even loss of consciousness, and then potentially the patient could die. So let's take a look at some of the different places that we can have an embolism. So what they're showing you here is a blood clot coming from the legs, right? This is the inferior vena cava coming up. It's going to dump the blood into the right atrium, and then from there the clot will go into the right ventricle, right? Here's the pulmonary trunk. Here's your pulmonary arteries taking the clot to the lungs. So if it's a single small embolus like right here, right, it may be silent, right? Just maybe blocking a small area of the lung, and there may not be any real symptoms. Over here, they're showing you multiple emboli equivalent to a large embolus. So here we have like 3 or 4 smaller emboli, right? That would be kind of mimicking a larger embolism. Over here is a moderate size embolism, likely to cause respiratory distress and then even infarction to the tissue of the tube or the tissue of the lung there. And then this would be a large one here, very large embolism or embolus that blocks the pulmonary circulation, leading to shock and then cardiac arrest. Right, so here the blood's not getting to either lung. And then ultimately, too, as less blood gets to the lung, that means less blood goes back to the left side of the heart, and now you can see the amount of blood as far as the cardiac output is going to be diminished. And so that's a pretty good picture, giving you some of the ideas where the pulmonary embolism can take place. So one of the biggest things with pulmonary embolus is prevention, right? Health teaching prior to surgery. Again, just teaching patients not to be stagnant. This is one of the reasons after most surgeries they get the patient up, sitting up, walking around. There's different types of stockings that the patient can wear. In the hospital, they have pneumatic stockings. If they are bedridden, you'll hear the pump go on, and then the stockings around the leg will inflate and then deflate. They can do exercise to prevent thrombosis, right? They always say, even on a long flight, say you're going to Europe or to, just a long flight, they tell you to curl your toes, paddle your feet, get up and walk around, right? One of the worst things you can do is just sit there, okay? And then there's different types of drugs that prevent the formation of the blood clots. All right, diagnosis, radiography, they can take chest x-ray, do different types of MRIs, pulmonary angiography, right? Just any type of diagnostic testing where they can see where the clot is in the lung. And then finally, the treatment is really, try to assess the risk factors, see who's at risk for it. Prolonged bed rest, like I said, and compression stockings. Surgical inserted filters are sometimes put in the vena cava. They can have heparin. Streptokinase is kind of like a clot buster. It's something that breaks down clots. If the patient is having difficulty breathing and there's damage to the lung, like necrosis, they may put them on a ventilator, and then they can do even surgery to, once they find that thrombus or the embolus, they can take that out. Okay, and that concludes our vascular and restrictive disorders.